Okay, Dr. Unger, I say we should get started. Definitely want to respect everyone's time. So let's kick it off. So welcome everybody. Good evening. My name is Christopher Garcia. I'm from the CeQur marketing team. So thank you for joining. We had two options today. The first one, excited to say that we had about 60 attendees. And this is the first time we're providing two options just to give folks that just need a little extra time to wrap up their day with patients. To get home possibly and to join us in this webinar. And also it's the first time, we're trying to make it convenient to folks out in the West Coast. Primarily, majority of our reps are in Central and Eastern time, but slowly but surely we're growing and coming out here to the West. So let's go ahead and get started. And if today's presentation is titled Removing Known Barriers to Mealtime Insulin Dosing. And our speaker today is a dear friend, Dr. Unger, and I will give him more of a formal introduction just in a couple slides here. And before we get started, and Dr. Unger, I did remember this time, my sticky note to cover housekeeping items. I just want to remind you all that the chat box and Q&A box features on Zoom are available for you to utilize at any point during today's presentation for you to type in your questions there. Our colleague from CeQur, Curtis Carter, is there behind the scenes to address your questions. Dr. Unger and I will have time after Dr. Unger's presentation to cover frequently asked questions and also to cover any additional questions that many of you may still have. So here are the topics that we have for today. We're first going to cover some introductions. And our first section here is to talk about the unmet need of insulin delivery that our product addresses. And then we'll talk about key features and benefits of our product, CeQur Simplicity, and then cover clinical data and user satisfaction data. And then after that, we will summarize the presentation. Next slide there, please, Dr. Unger. And now I do have the distinct honor to introduce our dear friend, Dr. Unger. So Dr. Unger, he directs the Unger Primary Care Concierge Medical Group in Rancho Cucamonga, California. He is also the Director of Metabolic Studies at the Catalina Research Institute in Montclair, California. His private practice is devoted to comprehensive care of patients, not only with diabetes, but also addiction, mental illness, migraine, and other chronic disease states. He is board certified in family medicine and has published over 250 peer-reviewed articles on diabetes, migraine, and pain management. Additionally, Dr. Unger has written 3 medical textbooks on diabetes, including the Diabetes Management in Primary Care, and that was published second edition in December of 2012. And last but not least, he is a fellow of the American Association of Clinical Endocrinologists. And some fun facts that I really enjoy about Dr. Unger is that he has served as a consulting physician for the Los Angeles Angels professional baseball team. I'm sorry, the Anaheim. Los Angeles of Anaheim is what they call it, right? Yep. And also he served as a consulting physician for the World Wrestling Federation. That is why you see that fun picture of him with Hulk Hogan. And I like to tease Dr. Unger that, next time he better choose a better photo, because my favorite wrestler back in those days was the Ultimate Warrior. So next slide, we'll cover just some key disclosures before I hand it over to Dr. Unger. So this program is sponsored by CeQur, and the speaker is presenting on behalf of our company, CeQur. Next slide. And at CeQur, we're very excited to simplify the lives of people with diabetes, and we strive every day to revolutionize insulin delivery by providing convenient, discreet, and injection-free dosing. And now I'd like to hand it over to Dr. Unger to cover our first section here, the unmet need in insulin delivery. And again, just a friendly reminder, please feel free to take advantage of that chat box and Q&A box if you do indeed have any questions throughout today's presentation. Dr. Unger.
Thanks, Chris. I'm honored to be presenting tonight for my peers, anybody else that might be listening. I want to thank you for the opportunity. As Chris mentioned, I'm a family physician primarily and a diabetologist secondarily. And I have patients using the CeQur, and I'm really impressed at how well this device can get these patients to target, to their glycemic targets. One of the patients, Chris, that you know, because you helped me train him, is Arnold. So Arnold is 75 years old. He's had type 2 diabetes for about 15 years. He originally saw me about maybe 8 months ago with an A1C above 9, probably 9.2, 9.5. Arnold has a lot of other medical problems, including Parkinson's disease. He's got arthritis. He's had trouble with staying upright, falls quite a bit. He's had a subdural hematoma. He's got a hypertension. He's a mess. And that's why primary care doctors really rock, because none of this stuff scares me at all. So Arnold is kind of a fun guy too, because he used to be a Vietnam War vet. In fact, he spent 5 years in Vietnam. 3 of those years were spent living in Agent Orange. So as you know, Agent Orange is a toxic chemical. It obliterates the pancreatic islet. So one of the reasons that Arnold's not doing well is probably because of his exposure to Agent Orange. As I mentioned, Arnold's he's got a hard time getting around sometimes. So I do house calls on him. And about 6 weeks ago, I went over to his house to see him, and I noticed he was walking with a walker with wheels. And he was walking kind of slow. And I said, Arnold, this is a really cool walker. Do you have a name for it? And Arnold said, yes, I'd like you to meet my girlfriend. You see, when I walk and I get tired because of Parkinson's disease or whatever, I just sit on my girlfriend, and all of a sudden I start feeling really good. Sometimes he says, I sit for 5 minutes, feel great. Then I get up and start walking again. About 6 weeks ago, actually about 3 weeks ago, Arnold went to North Carolina. His son is one of the NASCAR racers. So he likes to go to the pit row. The problem is that he fell down, injured himself, ended up in the hospital. And somebody looked at the CeQur pump, the CeQur patch on his abdomen and said, Arnold, what is this thing? And Arnold said, look, that's my mistress. You don't touch it. You touch my mistress, you lose your hand. So, Arnold, let me get this right. You've got a mistress and you have a girlfriend. He said, absolutely. And I love them both. So that's what I'm going to talk to you about, insulin delivery, a new way to successfully manage patients with diabetes. Right now, we've got about 30 million Americans that have diabetes. But the exciting part of this is we've got 92 million Americans that have prediabetes. Obviously, prediabetes precedes diabetes. But the interesting thing about prediabetes is these people are maximally insulin resistant. In prediabetes, you've already lost 80% of your beta cell function, which means the longer you have diabetes, the more likely you are to need insulin. And we've got a lot of people on insulin. We've got 5 million people in the United States that are on insulin. But if you take a look at history, back in 1921, there was no insulin. Insulin was discovered in 1922, and it really wasn't always a great story. In fact, the first articles about insulin use said that insulin is just a terrible drug. In fact, it was very painful to inject this. Nobody knew how much to inject. There was no A1C. There were no meters. There's really nothing you could do to figure out how your diabetes was doing. Before 1922, the only way that we could manage diabetes was with starvation. So we didn't have a whole lot of options, but insulin was a very potent drug, saved lots and lots of lives. Nobody knew how to inject it. Nobody knew how to use it. It was interesting in the 1940s, a lot of times people would hide in the closet and give their injections. In fact, there were spouses that never told their partners that they were injecting insulin. It was a stigma. It wasn't a cool thing to be injecting insulin. And it was also very painful. You inject, you'd have to be on the couch for about an hour recovering from that injection. So insulin's got a bad rap through the years, even though it's the most potent of all drugs that we have to lower A1Cs. You've also got about 2.5 million people that are using mealtime insulin. So let's go through this. If you use basal insulin with patients, the role of basal insulin is to lower hepatic glucose production, so you can wake up in a safe range. It's a lot easier to control diabetes when your blood sugar when you wake up is 80 rather than 280. So that's what basal insulin does. Mealtime insulin lowers postprandial glucose levels. So you want to keep that glucose level below 180. Why? Who said that? Whose idea was it to get the A1s, get the 2-hour postprandial glucose less than 180? There was an article published about 10 years ago that showed that if your glucose levels go above 180 for 2 hours after you eat, then you essentially get vascular inflammation. And this vascular inflammation does not disappear for 7 days. In other words, you lose 7 days of life. That's not good. So I don't like glucose levels going up. I want to keep the glucose levels down. I want to get those patients into control with their diabetes. Nothing frustrates a family physician more than not being able to treat to metabolic targets. So now we've got a lot of people that are struggling to get their A1Cs to 7%. In fact, studies show that only about 50% of the United States population are able to get their A1C to 7% or less. And we've got 255 different ways to treat type 2 diabetes. Well, why is that? They don't take the medicine. If you don't take the medicine won't work. So one of the things that we have to do in primary care when we're prescribing these drugs is to work on better means of adherence. Here's a problem. If you're on mealtime insulin and you know it's working, every once in a while, you're not going to take the dose. We know that. Let's say you're out with your soon-to-be wife, romantic dinner, you're out at a French restaurant, and the food's coming, and do you think the person's going to say, "Excuse me, dear, I've got to go to the bathroom. I've got to give myself an injection of insulin in the stomach. I've got to check my blood sugar too. I'll be back in about 5 minutes." No, they're simply not going to use the insulin. So if people miss the insulin, the drug isn't going to work. People forget insulin. Arnold, my Vietnam War vet guy with the mistress, he was always forgetting to take the insulin. And some of that might have been due to Parkinson's disease, but some of it was that he just didn't give it. Patients believe that if they eat a little bit, they don't have to worry about taking any insulin. It's not true. If they eat, their glucose level is going to go up, and they're going to need to use insulin to get that glucose level at less than 180 in the postprandial state. Something more terrifying that I see, and we see it a lot in primary care, is eating disorders. Sometimes people do not take insulin because they think it's going to make them gain weight. They're afraid of using insulin because of weight gain. On the other hand, we've got patients with type 1 diabetes that have an eating disorder as well. They may think, okay, I've got to go to a prom in about 2 weeks. How about if I just omit my dose of insulin? I'll go into DKA, I'll start puking, I'll have abdominal pain, I'll go to the hospital, I'll be on IVs, and before I know it, I'm down 10 pounds. This happens. So if you don't take the insulin, you are not going to be able to control your diabetes. Turns out that if you miss 4 injections of insulin for meals on a weekly basis, your A1C is going to go up 0.92%. Now, for those of you that don't understand what I said, let's go back here a second, digest the statement. What is an A1C? We always tell patients, your A1C is 7, your A1C is 7.2, you're 7.5. I mean, I've got hospice patients. I don't even care what the A1C is. It doesn't matter. But what is an A1C? Does the patient ask you? Well, an A1C is a reflection of glycemic control over a 3-month period of time. You see, diabetes is a very sticky disease. As glucose levels go up, this is glucose. Glucose is sticky. It's going to stick to something. And what it sticks to is hemoglobin. Glucose sticking to hemoglobin, that's called glycation. Once you glycate the hemoglobin, I don't have a crowbar. I can't pull it off. It's there for the life of the hemoglobin, which is a total of 90 days or 3 months. So glycated hemoglobin, again, gives us an understanding of what the glucose levels have been over a 3-month period of time. But it's not as easy as I just said. What's a normal glycated hemoglobin? Somebody that doesn't have diabetes, well, it's about 5.1%. That is, normal people have about 5% of their hemoglobin glycated to glucose. When do we start getting nervous about A1Cs? Well, it turns out 5.7 is the cutoff. That's when you get into prediabetes. So why 5.7? Well, at 5.7, turns out this is where you start getting microvascular complications, including eye problems and neuropathy. So we got to be really careful about not having our A1Cs go up too high. The higher the A1C, the more glucose toxicity, the more problems you start having with diabetes. Two more little caveats on A1C. Some people have false elevations of A1Cs. For example, those with anemia, iron deficiency anemia, these people become hyperglycators. They overglycate. So you may see an A1C in somebody that's anemic of 8.4, but in fact, if you look at sensor data, they might be doing perfectly well. And the opposite of that are people with diabetic kidney disease. So if you have diabetic kidney disease, these people may have falsely low A1C. So you may have somebody that's getting ready for dialysis and their A1C is 5.2 and you're saying, I did my job. No, it's a fake because the hemoglobin is destroyed more quickly in these types of patients. So again, we want an A1C of less than 7%. We want our patients to achieve successful, targeted metabolic management. So let's talk about CeQur Simplicity. The CeQur Simplicity is an on-demand insulin delivery system. It is intended for subcutaneous bolus delivery of insulin for the management of people with diabetes requiring insulin. The CeQur Simplicity on-demand insulin system has been studied in adult patients 21 of age and older who have diabetes. It is not intended if you're under age 21, and it is labeled for use with either Humalog insulin or Novolog insulin. Somebody asked me on a previous program here, well, what about like U200? Can I use concentrated insulin? The answer is no. It has not been studied. Not a good idea. So you don't want to be the first to jump on a bandwagon, the last to jump off when you're dealing with off-label indications. So first of all, the device is very convenient. And Chris, I'm going to bring you back in because we're going to show you some show and tell stuff right now. And this little device is really tiny. Hold it up. Yeah, that's it. And it goes on your abdomen. It sticks to the abdomen. There's an inserter. Chris, the inserter. Come on, there it is. And you put this together, you put it in your stomach on the abdomen, and boom, it's in, it's convenient. So it is designed for, again, delivering mealtime insulin. That's the purpose. Everybody asks, when you put one of these on, when I put it on, the first question they're going to ask, everybody except Dr. Brunton, because he doesn't care. I know he's listening. Can I take a shower with this? And the answer is yeah. You can swim, you can take a shower, you can jump out of planes, whatever you want to do, you can do it with this pump. I like this term in the second box here, discreet. We've got so many devices now for managing diabetes. I think it's a badge of honor to be seen with some of this stuff. I've seen them on the beach. I've seen them at the gym. They're wearing these devices. So I'll go up to them periodically and say, how do you like that thing? And they're going to say, you know what? This is great. It saves my life. It saved my life. It changed the way I deal with diabetes. It's like, oh my gosh, thank you for noticing. I have diabetes and I'm controlled. I'm having the best possible control that I can have. Good for me and good for you as well. This is injection-free. What you have to do, you load it up with insulin. It does not come preloaded. You place it on the stomach with the inserter, and then once it's in, you start bolusing insulin for meals. So I want to talk to you about how much insulin to put in this. And this is not part of the slide deck, but again, this is for injection-free dosing of mealtime insulin. So the question is, how much insulin am I supposed to put in here? Well, let's do some calculations. Normally, the recommended dose of insulin for meals is calculated as 0.1 units per kilogram per meal per day. 0.1 units per kilogram per meal per day. So let's take an example. Let's say you got a 100 kilogram guy. 100 times 0.1 is 10 units. That means this guy is going to need at least 10 units of insulin per meal. If he's eating 3 meals a day, that's 10 times 3. That's 30 a day, 30 units a day. The patch can be worn for 3 days. So 30 units times 3 is 90. Now you've got to put at least 100 units into this device for it to work. However, 20 units is required to prime it. So if you use 90 units, you got 20 more, that's 110 units. That's good. You could also give compensatory dosing. In other words, if the glucose level goes too high 2 hours after you eat, no problem. You could click the sides of the patch and deliver additional units. Every time you dose insulin by clicking those units, the sides, you deliver 2 units. The most insulin you can put in there is 200 units, but you have to put at least 100 units. So most of my patients are using about 130 to 150 units per 3-day wear. You see the guy on the right, the guy that's got his hand on his abdomen. So he's getting ready to inject the CeQur patch. He's smiling. Why is he smiling? Because of the patch? No, he's a Cubs fan. That's why he's smiling. He's watching the game. I know, I talked to him. So there's a lot of different ways that you can give mealtime insulin. How would you like to give syringe injections? Oh, that's good. I've seen this before, lots of times, where people come in with syringes and vials, they try to load it up. It's not accurate dosing. How can you load 10 units in a 100 unit syringe? It's never accurate. It's not right. So if you got to carry around all these devices with you all day long, if you're into numbers, you're injecting 1,095 times per year. So that's a lot of devices that you need to use. What about pens? It's an interesting story. You know, pens work really well. I really like pens, but the problem is you got to carry them around with you. Every once in a while, you forget the pens. And there's a couple of issues with pens. Number one, they will not work unless you show the patient how to inject appropriately. I am now going to demonstrate why my father-in-law years ago could not get his A1C down. It was my fault. And I was getting in trouble with my wife, Lisa, because he kept saying, Jeff, you're an idiot. How come you can't get my father's glucose levels down? You're supposed to know this stuff. This went on for like 2 or 3 months. Finally, I watched him. One day, I'll say, this is the insulin pen. It's not a regular pen. But the point is, he would take the pen and he was scared to death. He was closing his eyes. He'd raise the pen high up above his abdomen. And then kind of like a ride at Disney, he would, Pirates of the Caribbean, he would just, boom, put it in his stomach and pull it right back out. And all the stuff would come out. It would be insulin coming out, bile, pus, blood, everything. But he never injected until he pulled the pen out. I've had another patient, actually came from Dr. Broughton, that also was an injecting problem, because you see on those needles, those pen needles, you got to take the cap off. Dr. Broughton, if you don't take the cap off, you ain't injecting insulin. So this guy was injecting with the cap on. Too complicated for me, too complicated for a lot of my patients. So you can use a patch, put the CeQur on and place it on the stomach and just squeeze the panels on the side. And guess what? One insertion and you get multiple boluses of insulin with that. Instead of giving over 1,000 injections a year, you're down to 122. Good. So the FDA has labeled this patch as an OPP, which basically means bolus insulin only. That's nice. We have other devices out there that give basal bolus insulin. We have pumps that do that. One of them is the disposable Vigo 40 or Vigo 30 pump. We also have an Omnipod that does that as well. Plus, you've got these pens, you've got smart pens, you've got syringes. All this stuff is really good for people with diabetes. What makes the most sense? Let's go back to Arnold. So Arnold, he's got Parkinson's, he's got arthritis, he's got some mobility problems. Let's give him the device that makes the most sense for his individual needs. Do these devices work? And the answer is, yeah, they do. So functional testing was done that showed that the CeQur patch is safe, it's accurate, and it is reliable. Remember, reliability is so important. If you're injecting 6 units of insulin, you want to make sure it's actually 6 units. So it's reliable for mealtime insulin delivery. There were some user experiences studies done as well. So basically want to know, are the patients that use this patch happy with the device? And the answer is yeah. They have higher satisfaction and they inject more frequently than with the pen or with the syringe. Well, obviously they're going to inject more frequently because they don't have to worry about bringing it from home when they're going out to dinner, going to a game, going to the movie, whatever it is. They've got it attached to their body. And then there's a randomized controlled trial looking at the safety and efficacy of the patch versus multiple daily injections. This is a non-inferiority study. So we want to know, as scientists and as clinicians, will this actually do what it's supposed to? Will it lower the A1C just as good as people using other delivery devices? So this is the study. This is done by Rich Bergenstahl, thinking about 270 patients with diabetes. And the patients were randomized to using either a pen or a patch. They went for 44 weeks on this study, and then there was a crossover design. So the people that were on the patch were switched over to the pens. People on the pens went on the patch. So everybody got to experience everybody else's stuff. You could see on this graph that there are a lot of visits here. Some of these were phone visits, some of these were in-office visits. So the idea of this clinical trial was do everything you could to make sure that the patients maintained use of whatever device they were on. These patients had A1Cs 7.5 to 11. Baseline was around 8.3, I believe. The age was 22 to 75, and people were allowed to adjust the dose of their insulin. They have to, because if you're on insulin, you got to adjust it in order to get your A1C down to target. Now, when you look at this type of demographic graph, what you want to see is you want to ask yourself, do these patients look like patients that I see personally in my practice? So let's take a look at CeQur Simplicity. These people were on average 58 years, but they could have gone up to 67, 68. In Arnold's case, remember, he's 75. So they're a little bit overweight. They're about 200 pounds, and their A1C at baseline is 8.6. That sounds like somebody that I want to use insulin on as well. Also, look at the duration of diabetes. You're looking at almost 20 years. So by this time, you have very little beta cell function. Remember I told you before, even with prediabetes, you've lost 80% of your beta cell function. What are we waiting for? These people are going to need insulin later on. They're not doing well with their diabetes. Their A1C is high. Let's put them on something that may effectively get their glucose levels under control. The next thing you want to look at is how many people completed the study. So in 44 weeks, you see 108 of the CeQur patch patients completed, which is 77%, and the same with people on the pens going to the CeQur. So they were equal in their ability to maintain use of whatever device they were on. But the most important thing to me is, what about the A1C? You have an A1C baseline of 8.63. By 24 weeks, the A1C dropped by minus 1.7 for both groups. I'll show you in a second. So by 24 weeks, 63% of users achieved an A1C of 7%, down from a baseline of 8.6. I like that. That didn't take long. That took just 24 weeks. So I'll take anything that I can do to get the patient's A1C under improved control. And then by week 24, 85% of the patients had A1Cs less than 8%. You might say, well, that's not really good. I agree with you, but at least it's going in the right direction. And now you could add other meds or increase dosing, whatever you want to do to get the A1C down better than it was at baseline. So the study does work. This is what it looks like. Now, this is a non-inferiority study. So the goal was, we're using insulin, we're using pens versus patches versus pens. What works best? And the study says they both work the same. But remember, these people were in and out of the office. They were in and out of phone conversations. There are people that are coaching them the entire way. Again, the idea was, let's make sure this patch does what it's supposed to do. The change from baseline at week 44 was minus 1.63. This is my favorite slide because it talks about sensors. So there was a cohort of patients in the study that wore a blinded Dexcom sensor. So blinded means they don't have access to the data. But the thing is, if you have a sensor on, it's going to probably remind you to bolus insulin because you know you're being watched. So that we have a different concept to look at as well. It's not just the A1C anymore, it's time and range. Turns out that if you're having glucose levels evaluated every 1 to 5 minutes throughout a wear of the sensor, and you can get 70% of those glucose values in the range of 70 to 180, you're going to have an A1C of less than 7%. Let me go through that one more time. That's a lot of stuff I just told you. If you're using a sensor, your target glucose level is 70 to 180. If you can get 70% of your readings in that target range, you are going in the right direction. Patients are very likely to have A1Cs of less than 7%. So let's take a look at this graph. At baseline, for the CeQur patients, only 48% of these patients were the percent in range was only 48%. That's really good, not good at all. So 48%. In the pen group, 42% time and range, not good at all. So now at the end of the study, you increase that to 74% for the CeQur people, 75% for the pen people. Good for you. If you can increase time and range by 50% using these devices, you reduce your risk of microvascular complications by 50% as well. Good for you. Look at the A1C reduction. The A1C at baseline, 8.5 in this cohort. At the end of the study, 6.8 for the CeQur people and 6.7 for the pen people, essentially the same. I kind of like this graph as well. This is, again, sensor data. And you see the gray zone in there? That's what we call the target at 70 to 180. We want 70% of our glucose values in that range. So at baseline, only 48% of the patients using CeQur and using the pens were in this target range. But at the end of the study, 74% of these patients were in that target range. I like that. That's a good thing. So this is successful management of diabetes. You see on the left, the baseline graph, there's ups and downs of that sensor reading. This is the roller coaster of diabetes. People don't like going up and down. You don't like going from 40 to 400 on any given day. You want a flat line. And that brown area there, that brown line, that represents the median curve, the average glucose level on any given day for the life of the sensor. You want that to be as flat as possible. You can see there's an upward trend on the left and a flat line on the right. What about severe hypoglycemia? It was equal in both cohorts. What about discontinuation in this trial? Well, 3 people discontinued the CeQur, none stopped the pens. But again, CeQur is a medical device. This is not a bad number when you're dealing with devices. Some people don't like the adhesive. Some people don't like the application. Some people just drop out of the study for whatever reason. But overall, this study looks pretty good. There were 3 deaths in the study, 2 on the pen side, 1 on the CeQur side, but had nothing to do with the pen or the patch either. It had to do with cardiovascular demise. So if you look at how patients like the patch, 75% of them were satisfied with the CeQur Simplicity. 72% preferred CeQur over whatever they were on before. And 71% said, you know what? I'm going to tell my buddies about this as well. They recommend it to everybody else. So if you look at the healthcare professionals that were also involved in the study, they too were very happy with the CeQur advice. They said it's easy to start. It's good for patients that have type 2 diabetes. And it's simple. Patients like it. They seem to adhere to it. And this makes the life of the primary care doctor much happier. So a couple of things. This is a real world study. So patients were just given the CeQur device. And then 2 months later, they were given a questionnaire, asked some questions. And this is how they responded. So at the end of the study, after 2 months, 95% of these patients said, you know what? I'm completely satisfied with this device. But before they started the study, only 35% of the patients said, I love whatever I was using, the pens, the syringes and vials and so forth. So that's very, very good. In fact, it's important to note if the patient's happy with the device, they're likely to adhere to your practice recommendations. 93% of patients said the Simplicity is better than whatever method they were on before. If you look to the chart on the left, look at psychological well-being. You know, there's so much going on in people with diabetes. There's so many things that we people that are living with diabetes have to do on a daily basis. We've got to watch what we eat. We've got to count carbs sometimes. We've got to exercise. We've got to watch our weight. We got to take 8 of our other medicines. I had a patient about 4 months ago that newly diagnosed type 1 diabetes, blood sugar in the hospital was over 1,000. He came to see me and she started crying. She said, "Oh, I don't know what I'm going to do anymore. I just can't deal with this. I can't ride my horse. I can't take my kids to McDonald's. I'm finished." And you know what I said? I said, "Okay, Patty, let's stop this pity party. You are not going to have any problems with diabetes. I've got your back. I'm watching you. Let's get started on your treatment." So she wiped up the tears. She's on a pump right now, doing great. But this is a patient, like a lot of our other people that we take care of, that are just scared to death of having diabetes. They got people going around, the food police. You shouldn't eat that. You shouldn't do that. You need to exercise more. You're too fat. Don't drink alcohol. Oh my goodness, I can't do it. This device helps them manage their diabetes. And it shows here with Simplicity, they have a 3.65% acceptance rate. They love this stuff. So this is much better than at the beginning of the clinical trial. So in summary, I'm going to, before I summarize, Chris, I hope you're still there. I'm going to have Chris talk to you about how to prescribe it. Then I'm going to summarize and go through some questions that you may have. So
Dr.
send
Unger,
your questions in.
Dr. Unger always gives me all the grunt work, but I'm happy to do it. So really two key points when it comes down to prescribing is you have to remember that not only prescribing the product, but also a separate vial of rapid acting insulin. But let's first start with prescribing. That's step one, the 10 pack. So the 10 pack contains 10 of these. So the 10 of these here, it'll have the patch itself. That red part is the needle, which guides the cannula into the body, and it has a fill syringe as well. Separate to the 10 pack, you'll prescribe your inserter, and these inserters are reusable. They can be washed and cleaned. So the key thing is that it's reusable. The third step is to, as I mentioned earlier, to prescribe that vial of rapid acting insulin. Again, we are labeled for U100, Novolog, and Humalog. And just a friendly reminder, we have a fantastic CeQur care team, a customer care team that's there to support patients and also providers as well. There's their contact information if you'd like to jot that down. And my colleague Curtis has also put that into the chat box. And happy to say too that we, despite being an early stage company, we have great coverage. So it is a pharmacy benefit. And where we do have coverage on commercial and Medicare Part D insurance plans, we're seeing most patients having a copay of $50 or less a month. And of course, individual plans and pharmacy benefits will vary patient by patient. But we are seeing that great coverage so far in the stages of our company. And one thing I'll also like to stress as well is in terms of training, on average, people will take about 15 to 30 minutes to learn how to apply the product, how to dose the product, and how to replace it with a new patch. Feel free to utilize our customer care team for training. We do have nurses on staff to help with virtual training, or we can also have our nurses train someone at your office to train your patients how to use our product. So hopefully that's helpful information, and I'll hand it over back to Dr. Unger.
Thank you very much, Chris. See if I can get this thing to go again. Oops. There we go. All right. So in summary, before I give the summary, let's go back to Arnold. Remember, he came in with an A1C probably 9.2, something like that. And I saw him a couple of weeks ago doing great. He has an A1C of 7.5, and he is really, really happy. This is the first time in his life that he's got a control. And Arnold admitted that he wasn't giving insulin very often. Everything was just too complicated. There were too many things going on in his life that he just couldn't get control of his diabetes. So that's what we want. In primary care, we want to treat our patients to success. We do not want to treat them to failure. So we have goals. We have A1C targets, we have time and range, and our job as clinicians is to find whatever works to get those patients to their targeted goals. Remember, drugs don't work if they're not taken. So we've got to find a way that's comfortable, simple, and easy for these people to use on a regular basis. So CeQur Simplicity is a patch. It can be used to provide patients with mealtime insulin and lower your A1C. These are preferred over insulin pens. Patients like them. If you need the device, you can call this NIP. I think I pronounced that right, NIP RX Specialty Pharmacy, and they can get the devices over to them. So I think I answered all the questions, and I actually got through the slide deck here. And so what questions does anybody have at this point in time?
Thank you, Dr. Unger. Yes, we have plenty of time for questions, and I just want to thank you again for covering the presentation slides. And feel free to stop sharing so we could see your beautiful face and my ugly face nice and big for the Q&A. But we do have a couple questions that have come in. The first one is from Kathy, and is there a phone app that works with the device?
Answer, no.
So why you would think the device is so low profile is because there's no connectivity to it. Definitely from a commercial perspective, we are seeing that patients do love its low profile, and one of the reasons for that is because there's no connectivity to it, and that's one of the reasons how we were able to maintain that low profile. But to reiterate the answer, the question is there's no connectivity to the device.
You show them the bottom of the patch so they can see where the insulin goes. And there's a little filament there, a little cathode that goes inside subcutaneous space that delivers the insulin there. So it's a little container that really nicely stores the insulin.
So we do have another great question is for patients with shaky hands. And I do know the case that you mentioned, your patient who I had the pleasure to meet with when I went to your office, Dr. Unger. I believe you said he has arthritis, right? And I do remember when we were training him to use the product, he did mention that he has arthritis. Maybe you could speak to your patient's experience with his arthritis and learning to use the product.
It's not really arthritis as much as he has Parkinson's disease. So remember, with Parkinson's disease, you get really stiff. You can have a little bit of a tremor as well. This becomes problematic. And you're trying to inject insulin using a pen and just trying to get it in your skin is really, really difficult. So what we do, if a patient has a disability, they're not able to give the injection, let's find something else that will work successfully. Interestingly, he has no problem putting the insulin into the pump, putting the inserter and the patch together. That works very, very well. So patch, inserter, in, done.
Thank you, Dr. Unger. So we have more questions coming in. So thank you to the attendees for your engagement. Next question here is in terms of filling, let's say 160 units. So filling only partially, not the full 200 units. Would priming it be any different? So is there any difference in priming depending on how much units of insulin you're putting into the patch?
The priming is always the same. I can't remember if it's 16 or 20 units, but you add 20 units to the total just for the priming, Chris. That's necessary. That means it's got the insulin has to get from the pump through the cannula into the skin where it's going to be starting to be absorbed into the subcutaneous tissue.
Yes, and I'll take the time to toot my own horn for the marketing team. So we have great resources as well on our website. We have a quick start video on our YouTube channel, also on our website. And then also each prescription will come with a quick start guide booklet, and those instructions are very easy to follow. Dr. Unger was able to follow them that first time. So if Dr. Unger could get it, I think any patient can.
Yeah, it's true.
I don't know. I should be careful what I say. He'll take out those wrestling skills on me and body slam me. But let's see if any more questions, I also have other frequently asked questions that I think are also helpful to look at. And so can the patch be refilled or reused, Dr. Unger?
Yeah, because there's a retractable needle that when you use the inserter, it goes in and the needle comes out, leaving the little catheter inside your skin. You can't put that catheter back in a needle. It just doesn't work. It's not a good idea. So I know there are people out there that are trying to figure out how to do this. They're patients. You can't. It's not a good idea.
Another question that comes often is, I mean, since it is indicated for type 1 and type 2, so those type 1 patients that dose in 1 unit increments, how would you address that with our patch?
Yeah. So this is a device that can only be given in 2 unit increments. So every time you squeeze, you have your example there. You got the patch with you there, Chris.
Oh yes, sorry.
Yeah, pick that up. Okay, squeeze those little knobs. 2, and it makes a click. Hear that? 2, 4, 6, 8. That's it. Now, here's the thing I didn't mention. When you're out on insulin, if you squeeze the sides, it locks. You can't give any more. So therefore, this is only good for 3 days. You load it for 3 days, you use it for 3 days. There's a little sticker that comes with this as well, Chris, which is really kind of nice. It's in the box. So if you start the pump on Monday, you got to change it Thursday. There's a sticker that says change Thursday. So people like you, Chris, that don't know what day it is, when you see Thursday, you change the pump.
Hey, I know today's Tuesday. Give me a break. So thank you for those reminders, Dr. Unger. So yes, one of the safety features about our product is that you have the tactile and audible function features to it. That way you know you're dosing, right? As Dr. Unger mentioned, when it is out of insulin, those buttons will lock, and that's tells the patient it's out of insulin. It's time to replace it with another patch. So, Dr. Unger, have you had any issues with adhesion, rash, anything like that?
Anytime you're using an adhesive, there's a chance that could happen. But in the clinical trials, interestingly, nobody complained. It just didn't happen. So there are some people, and now you're not a clinician, Chris, but I know for the clinicians that are out there that nothing ever sticks to their body. Okay, this may not be the best choice to them. It's not a question of a rash, but it's a very rare phenomenon. I see it where sensors don't stick, pumps don't stick, patches don't stick, nothing sticks. And then you have to come up with a different treatment plan. But as far as rashes, don't see it.
So some other helpful tips in that regard is, and I know a lot of you providers have these tips for your patients, is that patients can augment the adhesion if it's needed by using any medical grade adhesive bandages or tapes. Some products out there, I believe they're called high tape, micropore, surgical tape. So those are some friendly tips that can help your patients. And also those are great, if your patients ever encounter any of those challenges, please, I encourage them to call our CeQur Care team or email them. And we're there. We have nurses on staff. They're happy to address any questions. I'm going back to the chat box here to see if there's any other questions. And here's a great question. Well, actually, it was a clarification that our colleague Curtis here provided. Another safety feature too, if for any reason during the insertion process, the application process, if the cannula becomes occluded, the buttons will lock. So that's another reason why, another safety feature, when it's out of insulin, the buttons will lock, or if there's any issues with the cannula, those buttons will lock, and that tells the patient that they're not going to dose accurately and they'll have to replace the patch. And let's go back here to any other frequently asked questions. Another common one that comes up too is if the patch tracks insulin doses. And Dr. Unger, I could take this one. So there's no tracking with the device, no connectivity, just to readdress that. And one other question for you, Dr. Unger, is can patients wear the patch during normal daily activities? I know you're a big time wrestler, so it's important to talk about activities and is it waterproof, etc.
Yeah, it's waterproof, and pretty much everybody can wear it. We have golfers wearing it. I don't know any pro athletes wearing it at this point in time. But as long as you're over 21 years old and you have diabetes, you can wear the patch. Why not? Give it a try. If that's what you want to do, at least you don't have to carry around extra needles and pens and everything else. You've got it on your body, which is a good thing.
Great, thank you. And we have another question that just came in from Gloria. Gloria, I don't know where you're from. We have folks calling in nationwide, but thank you for the engagement. Her question is, what if only one of the buttons is pressed? So as you can see, I'm pressing one button right now and you're not hearing it dosing. So that's another safety component. So say you're wearing the patch on your abdomen, you lean over and kind of over a table or something, and one of the buttons is pressed, it's not going to dose. It has to be two buttons at the same time. Great question. All right, well, I don't see any other questions, but like I said, if you do have any further questions, please feel free to reach out. I'll go ahead and get started with our conclusions here. I want to thank the audience for attending. I know it's late in the evening for you all, and thank you for allowing us the time to teach you more about our product. And actually, one more question did come in. We do have the time. Has our product been tested with visually impaired patients? Dr. Unger, I can address this question. I do know specifically we have not studied it with visually impaired patients. However, I do know though that we have some patients, I forget how many, maybe just one or two, that are blind. And we got specific feedback from especially their caregivers that it's a great option for them, right? And again, because of the tactile and audible functionality of it, so you can hear it and feel it being dosed. So with that, I do want to conclude. Thank you again to the audience members. Thank you to Curtis, my colleague, addressing the questions in the chat box. And to you, Dr. Unger, appreciate the time. It's always fun to partner with you. And without help from folks like you that join our speaker bureau, it definitely helps us to further educate from a peer-to-peer perspective about our product. So I can't thank you enough. And I'll allow you any time, the time you need right now to say your goodbyes.
Hey guys, you're busy. Thank you very much for attending tonight. You have questions, call your CeQur people. They're really, really good. And thank you for taking care of all of our patients.